there was an opening and I decided to do it. I have not done one myself before, so this is a first for me. And you can see that I am Dr. Jeffrey Freed, PG 42. Okay, no disclosures. I'm going to go through a case real quickly, origins of risk prediction in atherosclerotic vascular disease. I picked this topic because, a lot of people thought I was going to do a critical care topic. Because I do critical care, but I thought that actually it's probably more relevant for you guys to have a primary care topic. And before I get going, how many people have used the atherosclerotic vascular disease risk calculator? I understand it's actually built into your program, I guess, in the clinic. Yeah? Okay, good. So we're going to talk about that. And then discrimination and calibration, what those are, because I really didn't know. And maybe you do, but I didn't. And the data and criticisms, and then we'll talk about prevent. Okay, so this is the case real quickly. 67-year-old white male, father had a CABG for angina at 67, mother died of an MI at 78, no diabetes, never smoked, on an ARB and a diuretic for hypertension, which is controlled with a blood pressure of about 128. Cholesterol 221, LDL 96, and an HDL very elevated at 116 on a atorvastatin. So what is this patient's 10-year risk of an atherosclerotic vascular disease event, which means either a fatal or non-fatal stroke or MI? And should the blood pressure and or statin medication be intensified based on that prediction? So just really quickly, Framingham, should probably all heard of it. The heart study, I'm not going to go through this, but this was probably the first study, longitudinal study, where they actually developed a lot of these risk factors for atherosclerotic vascular disease and did create a prediction tool. And that prediction tool was subsequently updated. The risk score was updated in 2008, called the ATP3, which was a adult treatment panel sponsored by the NIH. And that was incorporated into a calculator. But it was felt to be not very accurate. It was not based on a huge number of patients. It was a single study in the cohort in Framingham, Massachusetts, so not very generalizable. So in 2013, the American Heart Association, ACC, decided to re-look at this because they felt it was important to be able to predict risk to make decisions about treatment, whether to intensify or start treatment for these patients, in addition to lifestyle modifications. So they basically looked at, they developed what are called the pooled cohort equations from 5 US studies, including the Framingham ATP3. But there was a total of only 25,000 patients in the 5 studies. They had no known atherosclerotic vascular disease history, so this was for primary prevention, not patients' secondary prevention, people who have already had a stroke or a TIA or angina or a MI. And the calculator predicted risk, 10-year risk for men, women, and white and African Americans, not other races, because they didn't have enough of those other races in the cohort of 25,000 patients. And they developed online calculators and apps, which subsequently were developed, which probably all of you have used. And you're using it in the clinic online. These are a couple of the apps. It's in MD Calc. It's in a lot of the medical calculators also. And they said that they recommended that for a first 10-year, for assessment of a 10-year risk of a heart first event, should be used in non-Hispanic African Americans and non-Hispanic whites. And also said that, interestingly, that it could be considered to be used in other races, which was never really looked at. Okay, so they also, in the same guideline, or in a companion guideline in the same issue, and this was published in mid-2014, said that patients with a 10-year risk of greater than 7.5% were considered high risk, and that initiation or intensification of a statin was strongly recommended for these patients in addition to lifestyle changes. That was a 1A recommendation. Also recommended considering moderate intensity statins for predicted risk of 5 to 7.5%. So you guys use these cutoffs, yeah. So these cutoffs, if you look at it, were based on 3 studies, which were of statin risk reduction, 3 randomized controlled trials. That's how they came out with the 7th, calculated that there would be a benefit to 7, greater than 7.5% versus risk of taking the medication. Unfortunately, when you look at those 3 studies, one of them was done in Japan, which was all Asians, obviously, which was not even included in the calculator. One of them was done in only high-risk patients, high CRP patients, high sensitive CRP patients, which wasn't looked at in the calculator in the development of the calculations. And the third one was in about 5,000 military patients, of which about 80% were men, so only about 20% of them were women. So not great studies to base these recommendations on. I'm not sure how they did that, but at the time, I can tell you that statins were like everybody was giving statins for everything, and they were trying it for everything, not just atherosclerotic vascular disease. And if you talk to a cardiologist at this time in 2013, which wasn't that long ago, 10 years ago, the cardiologist would say, they should just be putting statins in the water. Everybody, instead of fluoride, they should just put statins in the water. Everybody should be on this. Do you remember this?
Pneumonia treatment.
Pardon?
Pneumonia treatment.
Pneumonia treatment. They tried it in COVID. They tried it in dozens of different other diseases also, of which I'm not sure any of them panned out. Okay. So based on those recommendations of treating greater than 7.5%, that basically meant that they were recommending that 33 million Americans be treated based on those. Some of which may have been already treated, but a lot of which probably were not. So we'll go back to our case. If you plug it into the calculator, the 2013 risk calculator, the 10-year risk for this patient is 12.1%. Based on their recommendations, this patient should have more statins and or lower blood pressure. They're considered in a high-risk group, and a statin was strongly recommended. After 2013, based on probably this guideline, the number of individuals who use statins increased 149%. This is Americans, from 37 million to 92 million users in, what is that, 6 years, 7 years? It's pretty remarkable. That's an enormous increase in statin use based on these guidelines and this calculator. So how good is this calculator? I already told you there were some problems already with some of their guideline recommendations of when to initiate the statin, but what about the calculator itself? How good is it? How do you really assess that? And I really didn't know that before I did this, quite honestly. So I'm just going to spend hopefully 1 or 2 minutes on discrimination and calibration, because those are the 2 statistical terms that are most commonly used to evaluate a predictive equation. So discrimination is the ability of a model to discriminate between individuals who go on to experience an event and those who won't experience the event. This is often described as a C statistic. A C statistic of 0.5, which would basically be, and these are graphs on the side there, the line of identity would be 0.5. So a C statistic of 0.5 is basically no better than a coin toss, just to give you a reference. 0.6 is considered moderately good discrimination. 0.75 or higher is considered good discrimination, okay? And it really is talking about the area under the curve. Is really what it's calculating. The calibration, on the other hand, is the agreement between the frequency of observed events and predicted events. So if your calculator predicts 7.5% risk and your actual observed risk is 7.5%, that has excellent 100% calibration of 1, okay, which actually is on the line of identity. So as an example, a model currently estimates that the patient has an X has double the risk of an event as compared to Y. However, the model estimates that the probability of an event for the patient is X is 20% and Y is 10%, which is double, right? While the true probabilities are only 2 and 1%. So this model has good discrimination because it can differentiate twice as well as to who's going to get the event, but the numbers of the events are way, way lower than what was predicted by the model. So the calibration is very poor. Does that make sense? Okay, I'm not going to go through the second one. Although, since the treatment decisions that they're recommending are based on the risk probability as determined by the calculator, then really you want excellent calibration. If it predicts 7.5%, you want that population to have a 7.5% risk. And if you're going to base your treatment recommendations on that number, then it ought to be very close to that. Otherwise, you may be either under or over treating patients significantly, right? Is that clear? Okay. So out of the gate, within the same year these were published, there were already criticisms of this calculator. And you'll see, I'm just going to show a couple of quick studies. They were all published the same year in 2014. The calculator wasn't even published until July, I think, of 2014. So within 6 months, there were multiple studies looking at how well this model performed. And this was one of the first studies, and they basically said that one of the problems with the calculator is it didn't really include, it wasn't good for young people. Somebody who's 40 years old, their risk of dying of an MI in the next 10 years is very low, right? It's really low. It's not very helpful to know what the risk is in 10 years. You want a 20 or 30-year risk. What are they going to be like when they're 60 or 70? Are they going to have an MI, right? Also, it only went down to age 40. And they found that age is the single most important risk factor for this model. And you have no control over that, right? You can't treat somebody's age. So they also found, when they looked at it, even in individuals with optimal risk factors, meaning the best risk factors that you can put into the model, the 10-year risk was greater than 7.5% in all non-Hispanic women by the time they reached 65. Men at 65, women at 75, African-American men at 70, and women at age 70. Even with the best possible numbers, just because they reached that age, they already went over that 7.5% threshold by this calculator. There's another study also done in 2014 where they actually compared it to 2 external cohorts. One of them, the MESA study, which was a multi-ethnic study of atherosclerosis, a really large study, which also looked at other races. And they found the risk was significantly overestimated in all of these patients. The discrimination was suboptimal, where it went down to 0.56 in some of the cohorts, which was not much better than a coin toss, as I mentioned. And when applied to 3 large primary prevention cohort studies, the Women's Health Study, Physicians' Health Study, Women's Health Initiative, risk was also overestimated in all of them. And then this model, or when they looked at these models, nearly all African American men over the age of 62 would cross the 7.5% threshold and be considered high risk. This was the Women's Health Study, and you can see here's the line of identity where these should just be clustered around this line, and you can see it goes way off. This one was a study done in Europe because they wanted us to, all these calculator was developed on Americans. They looked at it and they found that nearly all men and more than 65% of women were recommended for drug treatment based on the guideline. And you can see the predicted risk is the dark bars and the observed risks are the light blue bars. And you can see there's a big difference between them, between the predicted and observed. And that's, and then this really large study done, and I put this in because in Northern California it's Kaiser, which does a lot of studies because they have a huge database of patients. They looked at a multi-ethnic cohort of 307,000 patients, which was 12.3 times larger than the 25,000 that was used for the derivation of the pooled cohort equations for the calculator. And they looked at multiple races. They found, and I'm not going to go through this, but you can see the orange bars are the predicted by the calculator, and the blue bars are the actual observed rates. And you can see there's huge differences between them. And they found it in basically every sex, race, racial, ethnic, and socioeconomic status groups. There's another one. This is diabetics versus non-diabetics, same study. It's a little bit closer in the diabetics, but still pretty poor. And then you can see the calibrations, they're not even close to the line of identity that you're looking for. So in 2016, based on all these criticisms, the USPTF basically said we're changing it to 7. We recommend greater than 10% because they realized that a lot of people were being overtreated by this. So they upped the threshold at which you should be treating based on the calculator. It also went in the other direction. So HIV patients are actually at significantly increased risk above the calculator. And you can see, as opposed to all the other graphs that I've showed you, these dark bars are actually patients are observed as a population of HIV patients. And the light single hash bars, the lighter bars, are the predicted by the calculator. So they actually do much worse. So there are populations that are much worse than the calculator. They don't claim in the calculator that you should be doing it in HIV patients. I just do this to point out that there are populations that you can't really use the calculator in. And then, so finally, this basically was kind of like a meta-analysis where they looked at multiple studies, the original validation. So even in the original validation, this is basically the calibration or odds ratio, if you want to call it that. So like in the original validation for Black patients, 5 to 7.5%, you can see it was 5 times greater than the actual observed rate, or 6.3 times for, I think for women. I think it was men and women. So when they went on and looked at a lot of other cohorts that were subsequently published after the calculator came out, and they basically bolded all of the numbers that were more than 1.5 times the predicted risk, or the predicted risk was 1.5 times higher than the actual observed risk, I should say. So really bad calibration. And you can see in a lot of these studies at various thresholds, 5 to 7.5%, 7.5 to 10%, and greater than 10%, there's lots of error. I mean, some of them are as high as 13 times. Also, the original cohort equations were based on really old studies, and there's been criticism that now with newer treatments and better treatment, that outcomes are better. And you can see that the studies, the validation studies were done on, or the derivation studies were done between 1968 and 1996, which is really old. And the validation studies were 1988 to 2008. Also, there's a lot about race now and trying to get race-neutral equations. And this study done by the Cleveland Clinic, basically, they had something called the, I forget what it's called on here, but a social discrimination, I guess, or not discrimination, social deprivation index. And they found that this was a very strong risk factor, stronger than race, really. So, so in the end here, what does the data tell us to do? We only have bad data on this. I think hopefully I've convinced you that the data is not very good. Does the bad data suggest we do what we wanted to do anyway? Well, yes, and that's called good data. And that's kind of where we are right now, right? So the American Heart Association, which helped develop the original calculator, basically recognized all these problems. There were problems with poor discrimination and calibration of the model. There were it didn't recognize cardiac, the interaction of cardiovascular, kidney, and metabolic diseases, which we now know are really important. They didn't recognize heart failure, which is actually increasing in incidence significantly since this came out. They recognized the need for a race-free predictor, substituting a sociodemographic index. They recognized the need for a more modern cohort with the benefits of antihypertensive and lipid-lowering therapies, recognized the need for a 30-year risk so that younger patients could be given a risk for, a 30-year-old could be given a risk for, you're probably going to have an MI by the time you're 60. And what they did was they basically created a whole new calculator, which just came out this year. Has anybody heard of it? It's called PREVENT. Okay, I'm going to talk about it just for a minute. I know I'm really running late. But they used, instead of 5 cohorts, they used 46 cohorts. Most of the things that I showed you on the previous slides, comprising not 25,000 patients, but 6.6 million patients. And they used half of the cohort to develop the model and the other half to validate the model. And basically, not only did they, as an outcome, not only did they look at atherosclerotic vascular disease as an outcome, but they also looked at total cardiovascular disease, which was a composite of atherosclerotic vascular disease plus heart failure. So now they included heart failure in the model, and they also list them as separate. So you can actually look specifically at what's the risk of heart failure, what's the risk of atherosclerotic vascular disease, what's the risk of all, any of them or combined. This is the difference between the 2013 model and the 2023 model. And in the new model, in addition to the same risk factors that they used before, there are a couple of big differences. One, they give you 10 and 30-year risk. It's race-free. They use a social deprivation index based on zip code. They give you all 3 outcomes there. They also added some other factors which can increase the calibration discrimination of the model. So if you have, and you don't have to use these, but if you have this information and put it in the model, it will be more accurate. So those include HbA1c for diabetes, estimated GFR, whether they're using statins or not, their BMI for obesity, the urine albumin creatinine ratio, and the zip code, which is a surrogate for the social deprivation index. Just to go back to our case, this was using the old model, the 2013 model, 12.1% 10-year risk. Anybody want to guess what it is under the PREVENT model? Well, I added in these additional data points, okay? So anybody want to guess what the risk was when I calculated this for atherosclerotic vascular disease? So that will be equivalent to the old model as the endpoint. 3, 4, 5, 4. It was 2.2%. Heart failure 2.3, and combined 3.5%. And here you can see this is the actual calculator. It's online. You can just Google PREVENT calculator and it'll come out. You can get that. It goes right to this and put in whatever numbers. Gives you the 10-year risk for each of these individually. I just put the atherosclerotic vascular disease one up here. Okay, so it's, what is that? It's almost 6 times higher risk than in the older calculator than the new one, which would mean on the old one, it was strongly recommended this person get increased statins or better control of their blood pressure, even though the systolic was only 128. And under the new one, there's nothing needed, right? So I'm not going to go through this because it's just a summary of everything I've said, and we're kind of out of time. So I think the whole point of this conference is to get rid of dogma and think critically, right? Yes?
where they're currently living, or like where they were born and raised?
No, it's where they were living at the time that they put them in the cohort.
Okay.
I think for maybe 5 years prior to the onset.
You sound like a health judge. Because that's important, right? Both of those things, right?
Yeah, I mean, clearly that is another could be another factor.
It's disappointing they didn't put HIV in the calculator, because what you described is actually one of the things that we use ASCVD in the HIV clinic all the time, and then we just do a fudge factor, assuming that you have to add 5 or 10%, because that's what some epi shows. So it's disappointing that we didn't, because the aging HIV population, people aren't dying of HIV, people are still getting infected.
Right.
The prevalence of HIV continues to grow, especially in people in their 50s, 60s, 70s, 80s.
Yeah. So I don't know how to incorporate it into this new calculator, but you'll get a better baseline from the calculator probably. All right. There's my references. Any other questions, comments before we stop? So I would hope that the clinic would somehow get this incorporated, this new calculator into your EMR. I don't know how long that's going to take. It probably took forever to get the old one in there. Yeah.
I wonder how the coronary artery calcium score would affect this, and also the Lp(a).
So they talked about that in the development of it, whether to include it or not, and I think they just don't have enough data to know how it interacts, because not enough, and they wanted to be able to use things that are readily, easily available, which coronary artery calcification scores are not paid for by a lot of insurance. They can be used. I think in a lot of cases it's not helpful, because if it's between 1 and 100, it doesn't give you an answer. If it's greater than 100, they say you should treat. If it's 0, you don't need to treat. So if it's 0, it's really helpful. Any other questions or comments? Okay, well, is it a myth? The 2013 ACC-HA risk calculator is accurate and should be used to make patient management decisions. How many people now think that this is true? How many think it's plausible? How many think this is just busted? Yeah, good. So I'm happy about that.